after treatment. So with that, we tend to try to, spare those surrounding organs as much as we can. So part of it is related to the radiation oncologist, um, ensuring that there's minimal scatter of the radiation. But there are also some adjunct or additional things that we can do to try to avoid mainly rectal irritation. As I mentioned, the rectum is very close in proximity to the prostate and can move throughout your treatment course. Radiation treatments usually last about 10 minutes, and during that process, you're going to move around a little bit. So if you're moving around, sometimes that can move the rectum into the field of radiation. So one of the options we talk about is, and kind of like we mentioned, the rectum is an organ at risk and can receive that unintended radiation to the point where you can get some bleeding, frequency, urgency to stool, and in some severe cases, what we call fistulas, which is an abnormal connection between the rectum and the urethra or the areas around the rectal opening, and does ultimately lead to a significant loss in quality of life. So one of the options that patients have to them is before doing radiation, you undergo what's called a space or hydrogel placement. This is a temporary injectable gel that is placed in between the prostate and the rectum to provide some additional separation between the rectum and the prostate. It's done as a minimally invasive kind of outpatient procedure, usually just with a little bit of anesthesia. And then over the course of, you go on to receive your radiation while the space or hydrogel is in place. And then over the course of the next 6 months, the space or slowly absorbs and is emitted through the urine. So it's made of a polyethylene glycol. It's synthetic but non-toxic and absorbs in, like I mentioned, approximately 6 months. It's placed during an outpatient procedure. We usually just give you a little bit of what's called MAC anesthesia, which is basically to make you fall asleep, but we don't have to put the tube down the throat or anything like that to protect the airway, because usually you'll sit still enough as long as you're asleep. And basically, the goal is to provide that separation of the rectum and the prostate to allow for the radiation to avoid additional scatter radiation to the rectum. Leads to fewer rectal complications, also fewer urinary complications, because you do push the bladder up away from the prostate a little bit too with the hydrogel, and ultimately improve quality of life by decreasing those symptoms like the urgency and frequency of stooling, the urgency and frequency of urination. It's a very commonly used gel spacer. It's been researched significantly and had a ton of patients kind of around the globe who have utilized it, and it is typically reimbursed by Medicare and a growing number of private insurances. So with prostate cancer treatment, I often tell patients that the initial treatment of your prostate cancer is the initial part of your journey. Our overall goal is definitely to rid you of the cancer and have strong oncologic outcomes, either with radiation or surgery. One of the things that will happen for the rest of your life is that you will have continued monitoring of your PSA to evaluate for any recurrence of the cancer. Our goal is that that PSA goes to undetectable, or at least a very low value, to have those cancer outcomes be as good as possible. But unfortunately, as we've kind of discussed with a little bit with the radiation and with surgery, the side effects of prostate cancer treatment tend to be very lifestyle limiting. The biggest one of those being urinary leakage and erectile dysfunction. So one of the conversations we have, if not before your prostate cancer treatment, but definitely in short order afterwards, would be talking about restoring your erectile function, restoring your continence. So about 10% of men are going to be, after prostate cancer removal surgery, are going to have leakage that requires more than 1 pad per day. That's more common in older men, especially over the age of 70. if that's when you have your prostate removed, those numbers get closer to 16 to 20%. So bladder leakage it can be either full bladder leakage or just some small drops where you require maybe just a pad for protection, but sometimes multiple pads per day that are fairly soaked. Typically, you'll have a catheter after surgery, and once the catheter is removed, you will leak, but that you slowly regain your continence over the course of the first 6 months. And by a year, you're kind of back to your new baseline. Persistent leakage of urine after prostate removal is called stress urinary incontinence. As kind of I mentioned, about 1 in 10 men will have persistent stress urinary incontinence, some of whom will be very bothered by that leakage. We talk about a lot of different methods of treatment. These coping options are really up here mainly for completeness sake, but a lot of guys will already be wearing pads or adult diapers. They'll use some sort of clamp or catheter device to hold the urine in. This clamp here is called a Cunningham clamp, which goes around the penis to prevent leakage from the penis, but those can cause erosions and irritations and all that kind of stuff. When we talk about more aggressive options for treatment of urinary leakage, basically comes in really 2 categories. One is what's called the male urethral sling, and the other what's called the artificial urinary sphincter. Again, injections or bulking agents are kind of up there only as a for completeness sake. There's really no injecting agent on the market right now that works very well. There's plenty that are in testing, but none have really panned out. The male urethral sling is intended to support the urethra to prevent leaks when coughing, laughing, and sneezing. Most patients are continent immediately following the procedure once the catheter is removed, which is typically left in for about 24 hours. The other option for management of leakage after prostate removal is what's called an artificial urinary sphincter. This is a device that comes with 3 components. One is a cuff that goes around the urethra and clamps around it to prevent leakage. The pump then goes within the scrotum, and a small pressure regulating balloon goes up by the bladder. Basically, when you squeeze the pump, the cuff loosens and allows you about 60 seconds to urinate before it automatically clamps back down around the urethra to maintain continence again. If you're experiencing any of these, please either do reach out, or if you need more information, you can visit this website, fixincontinence.com. It's a great site. It's got plenty of videos that talks about management options, as well as some patient testimonials about the options that I've discussed for treatment. Another important aspect of recovery after prostate cancer is restoring sexual function. Now, erectile dysfunction after any treatment for prostate cancer is very common and probably underreported. Most of the literature for erectile dysfunction after prostate removal is about 25 to 75%, whereas with radiation, it's probably about 40 to 60%, but everything teeters basically around 50%. My argument would be that it's quite a bit more. Basically, the nerves surrounding the prostate in both radiation and surgery are stretched and sometimes damaged to the point that erections are no longer possible. It can sometimes take up to 2 years to regain erectile function after prostate cancer treatment, but if you're not really seeing some progress by 6 months to a year, then my guess is that you're probably not going to regain full functionality. There are options for penile rehabilitation around prostate cancer surgery, but it's mainly to restore length more so than actual erections, because no medication has been deemed successful at improving postoperative erection outcomes. The treatment options for erectile dysfunction after prostate cancer treatment is fairly similar to, or almost exactly the same as what you would utilize if you had just general run-of-the-mill erectile dysfunction from an organic cause. Oral medications, most men are very familiar with these, with what are called PDE5 inhibitors or phosphodiesterase 5 inhibitors. These are Viagra, Cialis, Levitra. They are very good and have about a 60% responsiveness rate, except in men who have been treated with prostate cancer, where the efficacy is a little bit lower. Vacuum pumps, you can see by this picture here, you put your penis into the vacuum pump and create negative pressure to pull blood into the penis. You then need to use a ring around the base of the penis to maintain blood within the penis. They're good for erectile rehabilitation after prostate treatment to help restore and maintain length. But most of my patients do not like to utilize them for erectile function, basically because if you ever put a rubber band around your finger and let it sit there for a while, things become numb, get red, get painful. Same thing happens to the penis. Penile injection therapy, what's called intracavernosal injections. This is a process by which a needle is placed into the erectile body of the penis to inject some medication locally. Tends to be fairly effective. Urethral suppositories aren't really available on the market anymore unless you use a compounding pharmacy. I tend not to use them because patients complain quite a bit about burning, urgency, irritation to the penis and urethra, and they are not quite as efficacious as the shots. And then finally, but a very good option, especially men who have had a prostatectomy, is what's called a penile prosthesis. There are multiple different types, but the one that is most commonly implanted is, again, that 3-piece penile prosthesis. There is 2 cylinders that go within the penis itself, a pump that goes within the scrotum, and then a reservoir that goes up by the bladder. When the pump in the scrotum is cycled, fluid goes from the reservoir up into the cylinders to give you an erection. When it then stays in the erect state for as long as you want, for as many times as you would like to use it, and then you hit a button on top of the pump and the penis deflates. Everything is completely maintained inside the body. It offers increased spontaneity, so you're not fumbling around with needles or taking pills 30 to 60 minutes before you want to have an erection. And it lasts as long as you want. And so you don't have to worry about timing things or using things before things wear off. Again, if you have additional questions or concerns and want to assess yourself, you can go to edcure.org. Again, there are multiple videos and options talking about the best treatment course for you in terms of erectile dysfunction. Some frequently asked questions: how long does it take to achieve bladder control? Usually I wait till about a year after a prostate removal to assess continence. If it's very obvious that the incontinence is severe, then I'll do it at 6 months. Why don't all men recover erectile function after treatment? It really depends. There's a lot of different factors that play into it. As you can see, kind of there listed. Our penile implants covered by insurance, Medicare covers them, and then most commercial payers or private payers are very good about covering them as well, but we will check for you depending if you desire the procedure. Just a few patient testimonials. There's another reference to some of the websites we talked about today. Any questions? Looks like we have a few in the chat.
I can't see the chat questions. They went away from me. I'm not sure if you can see them on your
I can take a look at things here.
I think there was a lot that went through the chat that's probably not related. We were worried about the recording, but I can read one question that's in there. I can still see if you want me to read that to you.
Yeah, that works.
Okay. This guest asks if I want a pump implant to cure ED, approximately how long is the wait until surgery?
It's I mean, if you were in my office today and signed up today and fully cleared for surgery, probably sometime in October or November. Probably, I'll kind of expound on that question in terms of, anticipated recovery. Because I do, tell every patient that, this is a surgery. There is recovery related to it. I typically like you being able to use the device within 4 weeks from surgery. Um, with that being said, even after that 4 weeks, there are still some uh, recovery. You might still have a little bit of discomfort, a little bit of swelling. Hopefully by 3 months, all that swelling and all that discomfort is completely gone. And then by 6 months, it's basically a part of you. And you don't really notice it at all.
Dr. I see the next question is, what are side effects and recovery time for penile implant surgery?
So the recovery we just talked about in terms of that 4 week is my goal. The 3 months, everything should be completely resolved. And by 6 months, you don't even notice it's there anymore. In terms of side effects, there are surgical risks. It is a surgery, and so bleeding, infection, recovery from surgery. I typically will leave a drain in after surgery and then remove it the next day. The other side effects, it's a mechanical device, so sometimes they need to be replaced or revised. There are, it's a new way to get an erection now. There are some changes to the girth and the shape of the penis that are sometimes present, but not always. In terms of long-term side effects, my goal is that there are no long-term side effects. The biggest one would be that, if you're 55 and you have one placed, you might need to have it replaced before, maybe by the time you're 75.
The next question is, if I have ED and bladder leakage, can I get both of these surgeries?
Yes. So typically, it will depend on the severity of your incontinence if I will do them at the same time. I typically will do them at the same time, but there is some increased risk with doing them at the same time of developing an infection. It's not a very high risk, but there was a paper it's been probably about 5 or 6 years ago now that talked about doing both at the same time versus staging them. I am happy to do them both at the same time as long as we have a conversation saying, there's going to be a lot of new instrumentation to get used to once surgery is done.
There's a question about if you can review the penile implant and Medicare payment procedures.
That's a good question that I can't necessarily give you all the full details on. We have a prior authorization staff at my office who deals with a majority of that work. Basically, I can tell you the process by which we go through to do that. If we're having an office visit and you elect to proceed with the penile implant or the artificial sphincter, we will then have you scheduled for surgery. That scheduling of surgery will then prompt my prior authorization team to reach out to your insurance company, whether it's Medicare, Blue Cross Blue Shield, Wellmark, Aetna, United Health will reach out to your plan and insurance provider to get multiple pieces of information from them. But the biggest one that we will relay to you is what your out-of-pocket expense will be if there is any. For the most part, there's very little out-of-pocket expense unless it relates to your own personal deductible.
The next question is a two-part question. Our panelists, our We have a participant who's 82 years old and wondering
Mhm.
if there's an age limit and also if it's life-threatening if you're on blood thinners.
There is not an age limit. We will have a conversation about your other medical comorbidities and best options for you. If you are an older male who uh, has a lot of other medical comorbidities, whether it be blood thinners or so on, we would definitely need to talk to your primary care doctor to decide if the proceeding with surgery in general is right for you. But for the most part, if you're a healthy 82-year-old guy who's still sexually active and is having increased difficulty, then I have no problem with proceeding. I think the oldest person I put one in is 86 years old. Any other questions?
Actually, Carlos, I see one in the Q&A chat again. It says, going back to prostate cancer, has genomic testing improved diagnosis in the last 4 years?
Sorry, can you repeat that again?
Sorry about that. It says, has genomic testing improved diagnosis in the last 4 years?
Diagnosis of prostate cancer, yes. The field of prostate cancer genomics has grown exponentially over the course of the last 5 years. Pretty much every patient or a majority of patients who I biopsy or who come through our office will have some sort of genetic testing. Typically, we use a genomic test called Decipher at this point. There's a lot of different ones out there. There's Prolaris, there's 4K, and a few others that I'm probably missing. But that testing gives us an additional data point for your clinically localized prostate cancer. Now, if you are found to have advanced prostate cancer, which is no longer clinically localized, the uh, genomic testing expands fairly significantly, where we're testing for a lot more germline as well as somatic mutations, meaning initial tumor uh, markers inside you, or whether it's something that is more prominent throughout your germline, whether it's BRCA1, BRCA2, JAK, some other genomic type cancers. And it's a field that's rapidly expanding. So in the last 4 years, I would say yes. And there will be new treatment options based on that genomic testing probably within the next 4 to 5 years.
Great, thank you. And I think we may have lost Carlos. Let me
I'm
go
back
back
on.
up. You're back on, okay. I wanted to
The
read,
next question I see here is,
yeah, perfect, go ahead.
sorry about that, I'm having bad connection here, but I see the next question is asking about how hard is the pump to squeeze to get fully erect?
Yeah, so it's an evolving process. So the pump, when it's initially placed, and the conversation that I have a lot with a lot of patients is the body's goal when you put a foreign body inside you is to try to wall off that device. And so the body will create a capsule around the uh, implant, including the pump within the scrotum. The initial few times that you pump it, it's going to feel firmer than it will 6 months after the surgery. Um, that first few pumps, it feels a little bit firm. It's like, why is it so firm? Well, as you continue to pump it, you break down that capsule and make it thinner. So that by the time 3, 6 months out, it's very easy. I have most of my patients who do it one-handed. They can do it behind the back. They can, do it every which way you can without really much difficulty.
Well, it looks like we might have one more question that's related to this patient being 66 years old, and what can I do to be ready for the penile implant?
That's a good question. So being ready for surgery is really what you can do to be ready for the penile implant. So there are a lot of men who come in and they have diabetes, and that's the cause of their erectile dysfunction. And so we talk about management of their diabetes because we want you to have good blood sugar control around the time of the implant. Or if you're a smoker, quit smoking. Those are probably the two biggest things that we run into trouble with, because smoking and poorly controlled diabetes are going to be the things that inhibit your healing the most. But other than that, come in and have a conversation. We can talk about your readiness at that point.
Carlos, I think there's one more that we didn't get to. It's a little further up. Do you want me to go ahead and read that one? I am past 75 years old with a pacemaker and Watchman implant. I have no signs of prostate cancer, but if I do, can I still have radiation? What is the typical, and then it asks about costs of a penile implant. So I think the question is, if the patient had an implant and in the future had prostate cancer, could they still receive radiation treatment? I believe. That's how I'm reading it.
So
Can you see that in the chat?
yeah, I'm seeing the chat. At 75 with no signs of prostate cancer, a pacemaker and a Watchman currently in place, a lot of our discussion will wrap around, if you were ever to be diagnosed with prostate cancer, what your prostate cancer looks like and what treatment option is the best for you. We kind of talked a little bit about that active surveillance, which is we know about the prostate cancer. We're not going to let it get out of control, but treatment might not be the best course of action by meaning radiation or surgery. If it was an aggressive form of prostate cancer that you were diagnosed with, yes, you would still be eligible for radiation. As far as what is the typical cost of the penile implant, I don't know 100% exactly. If you were to pay completely out of pocket, we would have to come to an arrangement or agreement on your total cost, because it's not just the penile implant, it's the surgical time, it's surgeon time, it's staff time in the operating room. So there's a lot that goes into paying for the implant itself. And then the cost of the actual device varies significantly. It looks like we might have a couple new messages. Can you see my questions? I can see that question. If penis got small, what program do you have to make it regular size? So I'll put this in the context of prostate cancer treatment. So a common complaint about men after a prostatectomy is shrinkage or loss of both penile size and erectile size. That's for two reasons. One is that when we cut the prostate out, we do need to sew the bladder and the urethra back together, which can pull the penis back slightly, which can make you lose a little bit of length. Secondly, when you develop the erectile concerns after prostate removal, it's not if you don't use it, you lose it, but it is a process by which if your penis does not regularly fill with blood, like you would when you were young and you were, overnight, you were getting erections and all that kind of stuff, your tissue inside your penile and your erectile tissue does tend to get a little bit firmer, so it does not stretch as far if it's gone a significant period of time without having an erection. The treatment option for that is essentially two, and that's where we talk about the penile rehabilitation option of the vacuum erectile device. Basically what that does is it will pull blood into that tissue to try to offer expansion. The other is what's called a traction device, but I typically don't recommend that to men after prostate surgery. Any other questions? It does
Dr.
not
Dornbier, I don't see any other
look like it.
questions.
Any more are coming in. So thank you everyone for attending. I appreciate your time. I know everyone is very busy. And I would just like to, again, reiterate Mark's came on before and talked about the options with Team Blue, both the run walk this weekend as well as the dinner next week at St. Boniface. So if you have any questions, please reach out to my office. And I wish I had that number pulled up right now. I usually have it at the end of the talk, but I forgot to put the slide in. But we are at the Urology Center of Iowa or iowauro.com. All right.
Do you want to put that in the chat so that everybody can jot it
Yes.
down?
Sure.
Actually, you probably want to put it in the Q&A so that everybody can see it.
Let's see.
Maybe, nope, you won't.
Dr.
Never
Dornbier,
mind.
we'll
That won't
send
work.
an email out. We'll send an
Okay,
email
perfect.
out
Yeah.
and it'll have your details too.
Perfect. If everyone
Carlos.
look out for the email, we'll have that. Usually I have it as my last slide. How effective are the Kegels? Last minute question. Effective. It's a good way to rehabilitate those muscles. Sometimes we will send you to a physical therapist even before surgery to figure out how to do the exercises. But if you do have really severe incontinence, it's not going to be very effective with just the Kegels alone. Sorry, I saw that question come up and I figured I'd give it an answer.
Dr. Dornbier, thank you for your time and giving the presentation tonight. To the participants, thank you for joining us tonight. We appreciate your questions to the chat feature. We hope the webinar provided some insight on treatment options for these disease states and about solutions that can help restore dignity and quality of life. Dr. Dornbier, I will kick it back to you for any final closing comments.
No, thank you everyone for attending. Again, we'll look out for the email for our contact information if you'd like to schedule an appointment.
We will now sign off the webinar. Thank you and have a great evening, everyone.